Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Ibrahim Ali, 65 years old with complaint of fever. His vital signs, blood pressure 130/90, temperature 38.5, pulse rate is 110. Take history and address his concerns. Ready?
Yes. Hello, I am Dr. Mansour, one of exam candidate. I'm asked to take history and admit your concern after examination. Is it all right with you?
Okay.
Can I confirm, are you Mr. Ibrahim Ali, 65 years old?
Yes.
Yeah. What brought you, Mr. Ali, today to the hospital?
Yes, doctor, I am suffering from high body temperature since 3 days.
I'm sorry for that. And it started suddenly or?
Yes, it has come suddenly.
Suddenly. And during the last 3 days, it has special characters, increase in the morning or the night?
Yes, increase actually, and it's become higher than before. The last time I checked by myself in by thermometer in the home, it was 39.
Okay.
In the first day, it was maybe 37.8.
But you have not.
Sorry?
No, that's
Hello?
more in the night or something like that?
No, actually, it is all the day.
Okay. Do you have night sweat?
Yes.
Okay. What's about your weight? Do you have any loss of weight?
No.
Okay. Any contact with someone have the same condition?
You mean feverish patient?
Yes.
No.
Yeah, I don't. Do you have any contact with cattle or sheep?
No.
Okay. Do you have any headache?
Yes.
Okay. Any blurring of vision?
No.
Any
But
next?
I am became dizzy. Some dizziness.
Sorry for that.
And confused.
Sorry for that. Any neck stiffness?
No neck stiffness.
No neck stiffness. Any sore throat?
No.
Any weakness in the arm or legs?
No. But I feel also by rigors, doctor, and body ache.
Okay, sorry for that. I can give you some medication, paracetamol, to control if you feel unwell now.
Okay, thank you.
Do you have any cough
No.
or cough of blood?
No.
Any shortness of breath?
No.
Any chest pain?
No.
Okay. Any tummy pain?
Yes.
How severe is this tummy pain?
It is actually since after 3 days started. I am suffering maybe since 7 days from constipation, hard stool. It was firstly just flatulence or distension in my abdomen. Actually, I suffered from this before many times, but this increased recently, and there is diffuse abdominal pain actually since 3 days.
And sorry for that. And how severe is that from 0 to 10, where 0 no pain and 10 is the maximal pain?
It would be 6.
Will be so I should offer. I hope that paracetamol help in this regard to control this pain.
Yes, already I took 2 tablets of paracetamol.
Okay, when was the last time?
Maybe since 3 hours.
3 hours. And this constipation is only for in the last 7 days, or was before also?
Yes.
In the last, okay. Before that, we have normal bowel habits.
Yes.
Okay. And what's about your water work?
No problem in my water work.
Okay. Regarding amount, volume, any burning sensation,
No problem.
any frothy water work.
No problem.
Okay.
No
And
problem.
okay. Any tummy distension?
Yes, yes. I say to you, it is started by before this abdominal pain start. I suffered from abdominal distension and this
Mhm.
constipation. After that, there is abdominal pain.
Okay.
After
Sorry.
the high blood temperature start.
Okay. And any joint pain or back pain?
No,
Any leg swelling?
no. Also, as doctor, I suffering from also being sick and throwing up.
Sorry for that. Any difficulty of swallowing?
No,
Okay. I have a question regarding this tummy pain. Is that related to meals?
no,
No, like fatty meal or something like that. Okay.
not related at all.
Okay, and you have said that's all over your tummy.
Yes.
Okay. Do you have any similar condition before?
You mean what? Abdominal pain?
Yes, or fever or high body temperature? Or is
No,
it
no.
first time?
Recently, no. Recently, no.
Okay. Do you have any history of blood transfusion?
No.
Sorry for these questions, but I ask all of my patients any history of tattooing, skin piercing,
No, no at all.
or sharing needles.
No.
Okay. Are you married, Mr. Ali?
Yes, yes. I have 3 kids also.
Okay, sorry for that question. Do you have any relation outside marital relationship?
No, at all. No.
Okay. Do you have any history of long-standing diseases?
Yes, yes. I am have kidney failure actually, and this happened actually since 2 years, 2 years, and I am in since the start. I am in peritoneal dialysis, and planning now for renal transplant. I am on the waiting list.
Okay, and can I ask what was the cause of this kidney failure?
Yes, diabetes. I am diabetic since 15 years, and I was on tablets firstly, and then changed to insulin therapy after my sugar was uncontrolled. I am on insulin therapy since 5 years, doctor. I am taking Novorapid and Lantus. And now my sugar is controlled. My last accumulating sugar was 7.5.
That's good.
Also, doctor, I am hypertensive, and my cholesterol is high.
What medication you take for?
For hypertension, I am hypertensive since 10 years. I am on amlodipine 10 milligram, and for cholesterol, I am on simvastatin 10 milligram.
Okay.
Also, I am taking one alpha, and iron, and
iron
also injections for subcutaneous injections for anemia.
This injection once per week or
Yes.
or every 3 days. Okay. I understand. Sorry for that. Do you have any in the last time any over-the-counter medication or herbal medication?
Just paracetamol when this blood temperature high. Come on.
What are you doing for living?
I'm businessman.
Okay. How does it impact this?
Yes, actually, I can do anything since these 3 days and this high blood temperature because hypertension, dry gulls, and sweating. It is difficult actual situation.
Sorry for that. I I hope that I help you as rapid as possible in this regard, and I can refer you to occupational therapist also to help you in fixing this problem until your recovery. Do you smoke, Mr. Ali?
No. I stopped smoking since 10 years.
Okay. Do you drink any alcohol?
No, also now, no.
Okay. I have some question related to high
Sorry?
any numbness.
Hello?
I have question related to high blood sugar, diabetes.
Okay.
Okay. You have said you don't have any numbness on the arm or legs.
No.
Okay. And no heart attack before.
No.
Okay. And no stroke or mini stroke.
No.
Okay. And no blurring of visions.
Recently, I'm suffering
No vision
from
problem.
vision, and no. Recently, I am suffering from vision problem, and I visited my eye doctor, and he said maybe this is start of problem in your eyes because of this diabetes. I am already on medication for that.
Okay. And what's about your sexual relationship? Any disturbance or any abnormalities?
Yes, recently I am suffering from problems in erection.
Sorry for that. And what is about your legs? Do you have any pain in your calf, in the back muscles of your leg while walking?
No.
Okay.
No.
Can I examine you, Mr. Ali?
Okay.
I will start with the hand, looking for any clubbing, any splinter hemorrhage, any ossular nodules, any palmar erythema.
No problem in the hands.
Okay. I will do. Can you stretch your arm and hand, checking for flapping tremor?
No flapping tremor.
Okay. Thank you. I will check the pulse. This is 110 beat per minute.
Yes.
Okay. Equal
That's
in
right.
both sides. Regular.
Yes.
Okay. I will check the arm if any fistula or needle marks.
No, because the patient is on peritoneal dialysis since the start. I shared some pictures you can see
Okay,
also.
thank you. I will go for the neck veins. I show a condition.
Not raise, check venous pulse, not raise.
Okay, you have tummy pain now. I will press gently on your tummy.
Yes, there is tenderness all over the abdomen.
Okay, and if there is congested neck veins, hepatojugular reflex.
No.
Okay, I see the eye is some bulbar.
Yes.
Okay. And
Sorry?
and mouth cavity, tongue and mouth cavity.
No problem.
2 minutes
Okay.
left.
I will examine the heart.
Okay, cardiovascular examination is totally normal.
Okay, I will go gently for the abdomen, for the top abdomen, checking for any.
You can see. You can see
Yes.
the abdomen. You want to do anything? This
Okay,
picture.
and this. Thank you for that.
Okay, you can see the picture. You
Yes,
want
yes.
to
In guarding of the abdomen,
sorry,
the abdominal wall,
Balo?
in rigidity of abdominal wall.
No. Just tenderness.
Okay, sir. Good. I will go for lower limb, checking for any edema.
No lower limb edema.
Any. Okay. Do you have any concern? Thank you, Mr. Ali. Do you have any concern?
Yes, doctor. What I have? What's the cause of this high blood pressure?
Yes, from examination and your history for this fever, this dialysis catheter, there is redness and inflammation around that may go deep in the in your tummy and causing inflammation of the tummy wall, which may be responsible for this case.
You mean this catheter
You have
named?
it's well, that's one of the possibility. We will admit you and make investigation for you and do some investigation, and we'll start with the treatment as rapid as possible.
Okay, doctor.
You have
I
another
appreciate
question?
that. Yes, I appreciate that, but my main concern is this will affect my dialysis, routine dialysis.
That's a good question. If this is the case, we should. I will refer you to kidney doctor to consult him if it is possible to do this temporarily with venous with through the blood channel. If
Oh
it's
my God!
necessary.
You will change me to high hemodialysis?
I will consult the kidney doctor in this regard.
Okay. Okay.
But the
Okay,
first thing
Okay,
we
so
should control infection now.
time is up. Questions, examiner?
okay, can you present your case, please?
Mr. Ibrahim Ali, 65 years old, complaining of fever 3 days before he was complaining with tummy distension and tummy pains. On examination, there is tachycardia, no organ failure manifestations. There is pallor, and on abdominal examination, there is diffuse tenderness all over the abdomen. There is peritoneal catheter in place with inflammation and secretion around coming in the surrounding is connected with dialysis bottle, and the color of urine coming and the color of protein.
Okay. So what's your differential diagnosis, please?
Here is chronic kidney disease on peritoneal dialysis, complicated most probably by peritonitis.
Okay, so peritonitis,
The differential diagnosis may be the inadequate peritoneal dialysis, may diabetic ketoacidosis, because the patient, but the case is most probably with fever, is matching with sepsis.
Okay, so your first differential is peritonitis, the second is DKA, the third?
Kidney failure on top of chronic.
Sorry?
Acute on top of chronic kidney failure.
Acute on top chronic. Okay. Anything else you want to put as a differential? Okay. You want to put anything in the differential? Okay. So how you investigate this patient? How you investigate this patient?
It's complete routine blood investigation, complete blood count, liver function, kidney function, and electrolyte, C-reactive protein, ESR, blood culture from different 2 sets, and also abstract of the of this peritoneal catheter, please. See if any microorganism on the culture. I will do abdominal ultrasound to investigate.
Culture from where? Sorry?
From the peritoneal fluid and from this secretion around the catheter.
You mean you will do swab from the exit of the site. Okay.
Yes. Mm-hmm.
And you will take the sample from the
peritoneal
dialysis.
Fluids. From peritoneal fluids and also from urine. And I will do chest X-ray and the ultrasound of abdomen.
Okay. So how you will treat this patient?
Treatment of the patient here is a multidisciplinary team, including nephrologist, infectious disease, diabetologist, specialized nurses, and I will consult also intensive care unit to see if any indication for ITU admission and specialized nurse. Here is important in the first 1 hour is to take blood culture from both arm and the swab and start antibiotic as early as possible.
Can you clarify to me what's the antibiotic you will start and how you will start?
Yes, I will do multidisciplinary team, consult infectious disease.
No. About antibiotics.
Yes,
vancomycin.
vancomycin I can inject in the peritoneal catheter and block it for 48 hours.
Okay. So, any other medication you will give him other than antibiotics?
This IV fluids after consultation with nephrologist and to assess the volume status of the patient if any need for sepsis. That's the main and the usual medication as he take for blood sugar, insulin, and amlodipine. I will not stop.
Okay, the last question.
And antibiotics.
Is there any need to remove the catheter, and if the patient will continue peritoneal dialysis or not?
That's a good question. It should be the decision on individual basis. First, I have to check if any other differential diagnosis in the tummy, like acute cholecystitis or pyelonephritis as the cause. If this
no. If the patient confirms that he have a peritonitis.
Here, according to the regimen of hospital, some hospital will try with vancomycin intraperitoneal to inject and block the catheter, and some hospital, according to regimen, will take it out and give IV antibiotic and this transition with IV hemodialysis.
Okay, thank you. I finished.
Yes. Okay, well done, Dr. Ahmed. Now the comment, Dr. Hani. Based on the skills.
Okay, well done. Okay. Well done, Dr. Ahmed. Firstly, before I forget, you need to confirm the identity of the patient, Dr. Ahmed, before you make the agenda of the meeting. So I want to confirm that I am talking to Mr. Ibrahim. I am Dr. Ahmed or Dr. Mansour, the doctor in the clinic today. May I confirm that I'm talking to Mr. Ibrahim Ali? Okay. I am here to discuss his condition. I will. So you started by the agenda. After that, am I right, Dr. Ahmed?
Yes, doctor.
This is a side point, but it is important. Okay. After that, the main complaint here is fever. Okay, so you want to make good analysis of the main complaint. You did already, but some missed points in analyzing of the main complaint. It is asking about the aggravating or relieving factors. Okay. You asked about the other symptoms. I mean the general symptoms, other general symptoms. After that, there is 2 complaints in abdomen. You need to complete all the other symptoms of GIT. I say to you, there is nausea and vomiting. You don't ask it them, but I give the information to complete the all the overview about the case to put a differential diagnosis. So you need to complete all the GIT symptoms.
I don't know, but I want the history taking to search in this case for the focus of infection first. So I start from above downward. After that, I will do relevant system.
Yes, that's right. But if there is a complaint or multiple complaint in one system, you need to complete all the symptoms. I mean, you will ask tummy pain. Yes, there's tummy pain. You ask it about the side, the severity is very good. After that, you want to tummy swelling or tummy distension. Yes, there's tummy distension. You forget to feeling sick or getting sick or throwing up. Altered bowel motion. Okay, blood in the stool. You need to ask about your discoloration of the eyeballs or the skin, itching of the body, mouth sores, acid brush, heartburn, difficulty with swallowing. You asked about difficulty with swallowing. Okay. After that, you can make the systemic review. Okay. You asked about the genitourinary symptoms, pulmonary symptoms, musculoskeletal, joint bone. After that, past medical and surgical history asked. Drug history you asked. Family history you missed, I think. You don't ask me about the family history. Sexual travel history you asked. Sexual history you asked. Okay, social history you asked. Very good. Okay, so this is about the history. About examination. Okay, about examination, you need, in this case especially, you need to examine abdomen good. There is tenderness, yes, خلاص. You don't need to make deep palpation because of this tenderness, but you say to the examiner, I want to do deep palpation, but the patient is in pain and there is tenderness, I can do so. تمام. After that, you need to remove this dressing. If you see this picture, to see the this is if you open this picture, this is the insertion of or exit side of the catheter. Okay, but you want to remove the dressing to see. You can over this to the examiner. He may be no need. Okay, no need. Okay, you need to examine the peritoneal dialysis effluent. This fluid, it will be cloudy. In case of peritonitis, it's cloudy. Okay. As you see in the exit, you need to examine for any redness or discharge or swelling, exit site catheter. Okay. And as I said, a cloudy dialysate effluent. Okay. Okay. So after that, in the patient concern, this is a case actually of the diagnosis here. It is peritoneal dialysis associated peritonitis. Peritoneal dialysis associated peritonitis. So how you can explain this to the patient? Yes, I highly appreciate your concern. Mostly you have a medical condition called peritoneal dialysis associated peritonitis. It caused by infection by germs which entered in your tummy membranes, causing soreness inside and caused symptoms as you have. Okay. If the patient asks, how can you help me, doctor? Firstly, we will admit you and we will start we will refer you a team of doctors. Firstly, we will start by giving you urgent treatment in the
No, I don't hear Dr. Hani.
Yes, I am too. I think this connection.
You are hearing
Check
me
your
now?
connection. Yeah, we can hear you now. Please continue your talk. After you said, I will inject some medication to the catheter.
Yes. Give me, because there is a call, I will cancel the call.
We'll wait for you. I will comment temporarily until Dr. Hani will join. The clinical communication, I think, yes, I agreed about the borderline in this skill because you didn't ask earlier also about the past medical history. It's very important to ask these questions before or after the consultation. Why?
Sorry?
Yeah, I'm just giving advice regarding the history because he didn't ask about past medical history earlier, and he missed a lot of things when he asked it late. He asked about the past medical history after the systemic review. Then he discovered this patient is having diabetes and hypertension and kidney failure on dialysis. So everything will be changed again. I should ask more about this thing, and I could also include them in the systemic review question if I ask them earlier. So please, guys, anyone has a long clinical case, to ask the past medical history earlier before the systemic review, because you might change your systemic review question according to the past medical history. So as diabetes here, you cannot ask again, you have any frothiness of the urine because I didn't ask before. You have any change of the sensation because I didn't ask before. So the best way is to ask this question earlier after the constitutional symptoms. Okay. Continue your talk. Sorry, Dr. Hani.
Okay. So about and I will give you I will make admission to you, and I will give you after that antibiotic and the fluids, and we need to do some investigation to confirm our diagnosis and to detect the type of bacteria or germs causing this infection. Is it treatable, doctor? And does this will affect the dialysis? Yes, it is treatable. Most patients recover fully if treated early and correctly, and peritoneal dialysis will continue. But to be honest with you, repeated or severe infections can reduce how well the membrane works, and this will affect fluid removal or dialysis adequacy over time.
Even they might remove the catheter, Dr. Hani, if there is infection.
Yes, I will come.
Yeah.
I will come to this.
Continue. Yeah, continue. Okay.
If he asked about the dialysis, hemodialysis, or you will change me on to hemodialysis, or the catheter, as you say, Dr. Bassem, if the catheter is infected or the infection persists even with treatment, then we need to remove the catheter. Okay, so we need to remove the catheter if there is infection of the site, or with the treatment still there is infection. So we may need to remove the catheter, and only in cases of repeated or severe peritonitis might we switch to hemodialysis. Okay. There is some advices if the patient asks you to give him why this happened. So give me advices to not this happen again. So you will say the best way to prevent peritonitis is careful hygiene and correct dialysis technique, because the peritoneal dialysis, it is done by the patient himself. Okay. So he need to do careful hygiene and correct dialysis technique every time you do an exchange. What you will do, washing your hands well, wearing mask, keeping the connection area clean, taking care of the catheter exit site, and tell the doctor if you notice any redness or pain or discharge from the site of the catheter exit, okay? And follow up with your kidney doctor and avoid constipation. The constipation increase the susceptibility to peritonitis. Okay, so avoid constipation, and this because this reduces bacterial translocation. Okay. And early treatment if the catheter infection happened. About the differential diagnosis, Dr. Ahmed, the firstly will be the peritoneal dialysis associated peritonitis. The second will be exit site or tunnel infection. Okay. The third, you can put gastroenteritis, there is constipation, vomiting, okay, abdominal pain. You can put gastroenteritis. You put intestinal obstruction, there is constipation and vomiting. Okay. You can put also surgical causes of acute abdomen, like appendicitis, diverticulitis, cholecystitis, okay, bowel perforation. Okay, about the investigations, you put actually good investigation, routine investigations, as you say, and investigation to confirm the diagnosis. The first will be collecting
Dr.
sample
Hani,
from.
Dr. Hani, sorry to interrupt. You can add also DKA. Did you mention the DKA?
No,
Yes.
because his blood sugar is controlled now.
Okay, with any diabetic patient, you can put DKA as a differential, even especially if he's not well controlled. But even with controlled, you can mention it. He missed insulin dose.
Okay.
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 It's good
We
differential.
can
I
put
mean.
this.
Yeah. Okay. Continuous.
So about the investigations, you will do collecting sample from fresh peritoneal dialysis effluent and send it for cell count, a gram stain, and culture. You got fresh peritoneal dialysis. You will send it for cell count, gram stain, and culture. Firstly, about the cell count. If the white, we confirm peritonitis, if white blood cells, it is more than or equal 100 cells per milli. And 50%, more than 50% of these white blood cells is neutrophils. This will confirm peritonitis. A gram stain may be negative, but it is helpful if it was positive. Okay. I don't know, Doctor. Actually, I am
250.
I will confirm from that by according to what I read that it's more than 100, more than or equal 100 in the peritonitis. So a gram culture also to detect the organism. Blood culture, you can do blood culture if the case is severe attack or systemic illness, makes septicemia or like that. And also we will take swab from exit site, discharge if present. Okay. And you will do ultrasound, abdominal ultrasound, CT abdomen. Okay. If there is poor response to treatment or you suspect abscess or severe recurrent peritonitis. So about the treatment, as you say, Dr. Ahmed, admission and multidisciplinary team approach. Okay, kidney doctor, infectious disease doctor, non-pharmacological treatment, patient counseling and education, regular follow-up with and giving him advices about the technique of peritoneal dialysis and hygiene. Okay, pharmacological, first thing is empirical antibiotic, intraperitoneal empirical antibiotics, given directly without waiting the culture. Okay, mainly to cover staph aureus and pseudomonas. Okay, we can give vancomycin plus ceftazidime or cefazolin plus aminoglycoside. Okay, antibiotics will be given intraperitoneal, as I said, for 3 weeks, unless patient is septic. Okay. After that, you can modify the antibiotics according to the culture result. And also you will give supportive treatment in the form of fluids and antibiotics and pain control. And you will continue the peritoneal dialysis. As I said, catheter removal in special situations. If there is refractory peritonitis, I mean, if no improvement after 5 days, And if there is a relapsing peritonitis, fungal or mucobacterial infection, or repeated infection with the same organism. Okay. What is the most common organisms? Staph aureus and Pseudomonas. Okay. About the complication.
Epidermidis also one of biogram. Staph epidermidis and aureus as a skin organism, skin flora. And
yes.
also you can, as I said, Pseudomonas or other gram-negative E. coli, Klebsiella, because of the abdomen. And if there is also perforation, it could be more suspected. Okay.
Yes.
Okay, continue.
Okay. About the complications of peritoneal dialysis associated peritonitis. What is the complication can happen to this patient? Okay, in this case, can maybe develop sepsis. Okay, and hospitalization, fluid and electrolyte imbalance, poor dialysis clearance during infection, exit site or tunnel infection, catheter dysfunction or blockage, and need for catheter removal, temporary or permanent switch to hemodialysis, peritoneal membrane damage, recurrent or relapsing peritonitis, okay, or suffering from encapsulated peritoneal sclerosis. Okay, this is the most complications. I finished my comment actually.
Okay, we can also add the volume overload as the failure of dialysis or renal replacement therapy in this duration. If the patient is on hold or the catheter was removed, waiting for recovery, so the patient will have volume overload or hyperkalemia, as you said, electrolyte disturbance. You can add it to the complication, okay? Thank you, Dr. Hani. Well done as a preparation to the topic. Dr. Ahmed also, I want to say well done, but I think he missed a lot of the differential. He couldn't pick up the SBB, right? Dr. Ahmed, did you mention the SBB, spontaneous bacterial peritonitis?
SBB usually when liver disease, but if
Okay.
case of foreign body or something, it's simply
Peritonitis. Okay, peritonitis. You can say peritonitis. Okay. It's not spontaneous, but there is relation to the catheter, so it's catheter related. Okay, let's talk about the SAG. Is it important also here to do the SAG? And how much the ratio expected to
Yes.
find?
SAG should be low as
Perfect.
expected,
Perfect. It will be less than
less 1.1.
gram per deciliter. Perfect. Why? Because of the infection inside the fluid. Okay, but it's important to mention it. In particular, if you have chronic liver disease, if you suspect high protein, but here it's related to low protein, sorry, or the liver disease, you will suspect with portal hypertension. But here you will have the opposite. The cell count will be high, as well as the high SAG, or sorry, low SAG. Here it will be low SAG. Okay.
Yes.
Okay, regarding the physical examination, I will comment quickly about the steps. Examination also can be borderline because he couldn't do the examination of the deep palpation, which is important in this scenario. The other complication of diabetes, I don't know if he offered to examine if there is any association like peripheral neuropathy or other complication. Was it there?
The history was only impotence and eye problem, vision problem, and he was ophthalmologist.
Okay, good. Okay. Then they identify the signs. I think he could examine the site. Did you offer examining the site?
The site of what? Sorry.
The catheter.
Yes,
Did you
yes.
remove the dressing? You offered to
There
remove.
is one picture.
Yes, you saw
that-
it. Okay, if
Yes.
the exam, if you are in the exam and there is dressing, you have to remove the dressing, or at least to offer it.
Yes.
Okay. Then the differential also will be as borderline because you miss most important differential, and the concern welfare will be maintained. You write the judgment in the chat box. Any question before moving? Should offer fundoscopy? Yes, you should offer if there is any vision issue. You have to offer it. Although the examiner will tell you no need because this is not the time. Yes, it's one of the complications of poorly controlled diabetes, but it's not related directly to the case. The case here related to the peritoneal dialysis, catheter, and peritonitis. So all or most of the examination and finding will be in the abdomen. Full examination of the abdomen, inspection, palpation, percussion, auscultation you should do, plus the site of the catheter. Okay? Any other question or comment?
Yes. Assalamu alaikum.
Alaikum assalam. Go ahead, sis.
Yes. Fever. It looks like easy case, but it is not very easy. Just my comment in his clinical communication which is very important because this is fix the area which we should be focusing. Since he is starting with fever, as you have mentioned to him, he's not just fever in touch. And the candidate, Dr. Hani, he's volunteered to give most important information which is not given in the exam. Like what? When he mentioned that there is fever and something like that, the candidate volunteered to give him that there is rigors which should be asked. If not asked, they won't like that because this means sepsis or something like that. Shiver is very important. Shivering and sweating, when it is positive, should ask about this. Is it like excessive sweating? You need to change your clothes because maybe the patient dehydrated here. And also, what in the fever, he asked about confusion, neck stiffness, and as you, Dr. Basim mentioned to him that past medical history, Dr. Ahmed, if you ask early past medical history, the area of systemic review will be very clear to you because when you visit kidney failure and you already ask about water work, any change in water work, just water work like this. But if you know kidney failure, will mean dig more, low amount, dysuria, something like that. Then also Dr. Hani mentioned to you, it's very important to dig in that after tummy pain, distension like that, yellowish discoloration of the eyes, because you screening as generally in fever. Then when we focus in the kidney problem, he is volunteered to give you diabetes, everything's about diabetes, finish. He didn't give you a chance to ask another question with accumulation and everything's clear. Kidney also. And this is also, it is not in the exam like this. They waiting for an important area surrogate should be asked. In the examination, missing important area, we assume this is just, we know everything, this is catheter here, but unless you have been asked, or offered to do GVB, basal brachial ascites, you already are examined for lower limbs, because this is maintains the safety netting of the patient. Is this patient with this sepsis or infection on failure or not in failure? Very important to show the examiner, is this patient apart from this, is it failure or no? Because one of your differential there, you have mentioned acute and chronic renal failure. If he is toxic with you, he will ask you which area here in the examination or in the history tell you this patient in acute chronic failure. You have to offer to do blood glucose, bedside blood glucose. You have mentioned that when differential decay. How you know this is decay? Blood glucose ECG in this patient, blood pressure sitting and standing, because the patient's sepsis, maybe it is not easy sepsis. Kidney failure may be neutropenic sepsis. This is very important. When you start your treatment, you should start by vital stable correction and antibiotic, temperature chart, because the main presentation is fever. After antibiotic, then antibiotic, because prioritizing the things, it is very important in some cases like an emergency. Thank you very much. You have know everything about the case, but the skills to put it is very important. Thank you.
Yeah, thank you, Doctor. Thank you, Dr. Mahira, I guess, right?
Yeah, yes.
Okay, thank you, Dr. Mahira, as usual. I am the one added DKA. It's not relevant, but you can put it whenever you have abdominal pain with vomiting if you have diabetic patient. So you can put it as a differential. although you can say against the DKA, the patient is having good history of good, controlled or good controlled diabetes. So you can add it in this way.
But blood glucose bedside test is very important. If DKA or not DKA, as the patient background.
Yes, it's important to add it.
Anything. And this
Continue.
affects the welfare of the patient, by the way. It is very important.
Yeah,
Safe.
it's important. Vital signs, try to put it as a usual comment and usual question whenever you start the examination. Do it as a habit. I want to know the vital signs of this patient. Either the exam will tell you outside, or he will give you a number, or he will give you a skip. If there is something important, he might tell you there is hypertension, there is hypotension, and don't forget the posture hypotension. I would like to ask for posture hypotension. Either he will tell you skip or it's normal.
Yes, and Dr. Hani mentioned to him family history omit. Maybe what is the cause of kidney failure in this patient? Maybe patients need genetic counseling, maybe other polycystic kidney disease. What is the problem inside the patient? What is the cause of this kidney failure? Maybe from diabetes or other genetic disorders. We need also to mention that controlling of the diabetes is one of the measure that controlling the kidney also function.
Perfect. You can add it to the team as a multidisciplinary whenever you have a patient with kidney failure. So I would like to screen his family if there is possibility to be having a kidney or genetic condition like adult polycystic kidney disease. Perfect comment. Thank you, Dr. Mahira. Any other comment before moving to the next scenario? Dr. Ahmed, you can post your scenario, please.
I have.
Okay, Mrs. Alia Abdullah Abdul Fattah, 30 years old, with complaint of tiredness. Dr. Hani, 2 minutes, then we'll start.
Okay.
I want to give positive comment on one question Dr. Ahmed asked here about contact with sick patient. You can write these 3 questions with infectious disease: contact with sick patient, travel history, and neck stiffness. They are very important questions and clues to your case. Let's repeat them. Contact with sick patient. So if I have TB, I can pick up this question I can pick up the diagnosis. The second question, travel history. So if there is travel, I will analyze the travel. It could be related also to the infection state of this patient. And the third is, sorry, I mentioned the neck stiffness. The neck stiffness and fever means there is serious infection in the meninges, and I can roll out or roll in the meningitis. Okay. 3 questions, very important to the fever whenever you have fever history. Of course, after the systemic review, you can pick up where is the area of infection. By the way, fever means there is infection, and you have to know where is the area. The CNS, the cardiovascular, infective endocarditis, chest, TB or other infection, pneumonia, abdomen, gastroenteritis, urinary tract infection, and connective tissue disease. Of course, you can add to them, and joint or musculoskeletal joint arthritis, for example. Okay. Or HIV. The questions also of HIV is very important here in this scenario. And I want to answer, Doctora asked about sudden onset of fever. Yes, sometimes the onset means appear suddenly, means just yesterday. So I had, the fever yesterday appeared suddenly. I felt myself like sore throat. Patient suddenly will have the fever. So the onset means either acute or chronic or subacute. You can also say sudden means appeared yesterday or today. Okay, so it's okay to ask about the onset. Is it appeared suddenly or since long time? For example, patient will come after 3 weeks, appeared gradually. So he will tell you, yes, since 3 days, it comes and goes. This is the meaning of gradually. One very important question also you can add here, the cyclical fever. Whenever the patient is having fever, comes and goes in regular manner, you have to suspect malaria. And what will support the malaria? The travel history. Okay.
I have a comment in this case, Dr. Basim.
Okay, go ahead.
Okay. When patient presented with fever in the emergency department or whatever, the first contact is with the nurse, and the nurse will do triage. The nurse is educated and ask him some question to localize with the focus of infection. And if the patient said, I have abdominal pain, and said diffuse abdominal pain all over the abdomen, it is a surgical case. The surgeon will contact him at first, exclude surgical causes, first doing blood investigation and the ultrasound. After that, will refer the patient to me as internist. That's the daily work, what happened actually.
Okay, thank you, Dr. Ahmed. Dr. Hani, are you ready to start?
Yes.
Okay, here you go.
Hi there. I am Dr. Abdul Hafiz, a doctor in the clinic today. Can I confirm that I am talking to Ms. Alia Abdul Fattah, and you are 30 years old?
Yes, doctor, I am.
Nice to meet you, Ms. Alia. Ms. Alia, I am here today to discuss your health condition. So I will ask you some questions, and after that, I will examine you and address your concerns. Is it okay with you?
Yes, doctor, that's why I'm here.
Okay. So can you tell me what brought you in hospital today?
Doctor, I have no power. I cannot work as before. I'm tired all the time.
Okay, I'm sorry for that. Can you tell me more about this tiredness?
So I have noticed in the last 6 months it's going worse every day. I have tried to do
Okay.
sport, but didn't help me.
Okay, I'm sorry for that. So I will try to do my best to help you. So this tiredness started only since 6 months?
Yes, I have noticed since 6 months.
Okay, and this first time?
I have not.
Sorry?
Yes, it's first time. Yes.
Okay. Okay. So it is come suddenly or gradually?
It's gradually, it's worsening.
Okay. And it decrease or increase or decrease or the same?
It's worsening, doctor. Get worse.
Do you notice anything increase this tiredness, like exercise, like work?
No, actually, first it was heavy exercise or excessive work, but in the last time also when I doing the homework at home, I feel tired.
And do you notice anything relieves this tiredness as rest or sleeping?
No, when I sleep and I'm in the morning trying to do something, I feel tired also. I have no power more.
So it is all the day, or in the morning more, or night more?
I didn't. I'm not sure. I didn't notice any difference.
Oh, okay. Okay. So it is all the time, all the day, not coming on and off.
All the day. Yes.
Okay. So do you notice any dizziness?
Yes, I feel it's not dizziness. It's like lightheadedness.
Lightheadedness. Okay. So do you notice you became pallor, or anyone informed you that you became pale or before that?
I didn't notice pallor, but I got some my GP and he done blood test and say to me, you have iron deficiency, and give me iron supplementation, but no difference. I didn't help. I'm taking that's the second for iron
So,
supplementation, and however, I didn't feel any difference.
okay. So, do you have any high body temperature?
No.
Okay. In any change in your weight?
I'm not sure. I didn't. I think it's the same. I didn't lose any weight. Maybe
Any
one
change in
kilo.
your appetite? 1 kilo loss.
Maybe. Okay, yeah, maybe. I'm not sure.
Any change in your appetite?
It is the same.
Okay. Any lumps or bumps in your body?
No, doctor.
Any lump in your neck, in front of your neck?
No.
Okay. So you said there is a headache. It is since when this headache?
No headache. It's light-headedness.
Headaches. Okay. So there is any headache? You have suffering from any headache?
I don't have any headache.
Any loss of consciousness?
No, doctor.
Any weakness in your limbs or in your body?
I feel tired. All I have no power, but no weak.
I mean by weakness, you can't move your limbs or legs.
Yeah, I can move. I still going to the work every day.
Okay. Any change in sensation in your body or feeling numbness, pins and needles?
No, I didn't.
Okay. Any shaking of your hands?
Yes, sometimes.
Okay. Since when?
It's for a long time.
Okay.
When I take something sugary or something like that, I feel better.
Any sweating in your hands?
No.
You said the shakiness of your hands, but when you take something sugary, you improve. Am I right?
Yes. Yes.
And in this situation, there is any other symptoms you have in this situation when there's shaking of your hands?
What do you mean with other symptoms?
I mean feeling hungry, feeling.
Yes, maybe a hunger pain, but I have learned when that come or something, I should eat some sugary.
You are suffering from any long-standing disease?
No, doctor.
Okay. So, do you have any chest pain?
No.
Any shortness of breath?
I feel tired. I cannot describe it as shortness of breath, but I think no shortness of breath.
Any cough?
No, doctor.
Any racing of your heartbeats?
Yes, when I do exercise in the last time, I feel my heart racing.
Okay. Any coughing of blood?
No, doctor.
Okay. Any tummy pain?
No.
Any tummy swelling?
No.
Any change in your bowel habits?
Yes, I have loose motion.
Since when?
I'm maybe 2 years
2 years.
or more than. Yes, 2 years or more than 2 years.
Okay. So, any specific diagnosis for this loose motion?
No, I didn't talk with my GP about that.
Okay. And you are not on medication for this loose motion?
No, I didn't
Okay.
see
So
any
this.
advice.
It is watery solution.
It's soft, somehow soft.
How many times per day?
It's different time,
Okay.
times per day.
Sorry.
Between
Okay,
2
it is
and
bloody.
3 times per day. No blood.
Bloody.
No, doctor.
It is difficult to flush. Sorry for that.
Yes, it's I should press 2 times on siphon to get right.
Okay. Okay. So, do you have any mouth sores?
No, doctor.
Any heartburn?
No.
Any throwing up?
No.
Any problem in your water work?
No.
Any joint pain?
No.
Any skin rash?
Yes, I have skin rash, but it is gone now. Didn't have anymore.
Okay. Where's the site of this rash?
This was around my elbow.
No. Okay.
It took about 2 weeks and not more.
Okay. Is it itchy?
I cannot remember.
Scaly?
I don't know. It is some fluids from it to that time. After that, it healed and was okay.
Okay. So, any family history of the same condition?
No, doctor.
Any disease around your family?
I don't know.
Can you show me your medication list?
I don't take any medication, doctor.
Any recent travel history?
No.
Are you married?
Yes, doctor. I'm married.
Okay. And how many kids? Any children?
I have 2 children.
Okay. Any birth control pills?
No, I am lactating now, doctor, and I don't have any period more.
Okay. What are you doing for a living?
I'm teacher.
Do you drink alcohol?
No.
Do you smoke?
No, doctor.
Okay. Can I examine you?
Of course.
Okay. Firstly, I will general look. Any pictures you have to travel?
Average build.
Okay. I will check the hands. There is balloon. Okay. And the hands, an abnormality in the hands.
What you want to see?
Any clawing, any pulmonary edema, any deformities, any rash, any skin tightness.
No.
Okay, I will check the pulse and vital signs.
The pulse is 75. Blood pressure 100
Okay, I will.
to 70.
Okay, eyes and mouth examination, an abnormality.
There is hyperpigmentation in the mouth cavity.
Hyperpigmentation. Okay, in the tongue or in the mucosa?
In the mucosa.
Okay, I will examine the neck for any lump.
No thyroid enlargement.
Okay, I will examine the abdomen. Full abdominal examination.
What you want to examine?
Superficial palpation, deep palpation, percussion.
Superficial palpation, no tenderness, no palpable mass, deep palpation, no organomegaly, percussion, no ascites.
Okay. After that, I will examine the chest, the heart examination.
The S1, S2 normal. No additional murmurs.
Okay.
1 minute left.
So lower lymphedema.
No beat.
Okay. So what's your concern, Ms. Alia?
Yes. What's wrong with me, doctor?
Ms. Alia, I appreciate your concern, and from our discussion and examination, you mostly have a medical condition called celiac disease. Do you ever heard about this disease before?
No, doctor.
Yes, this is a disease affecting your bowel, and mostly it is a problem in the defensive system, attacking the lining of the bowel, causing this loose motion you are suffering, and causing some complications like iron deficiency anemia you have, and this causing symptoms of tiredness. Do you have any other concern?
Is there any treatment, doctor?
Yes, we will refer you to a team of doctors to give you the proper management plan. We need to do some investigation to confirm our diagnosis, and after that, the treatment will be to avoid the gluten containing foods, and the treatment of the iron deficiency anemia.
I have
Time is up.
iron supplementation. Okay. Present your case, doctor.
Okay, I examined this patient, a female patient, Miss Alia, who was coming with 6 months of tiredness and fatigue. She also suffering from confirmed case of iron deficiency anemia, and this shaking of her hands also, and there is diarrhea since 2 years. It is mostly malabsorptive diarrhea, and also by examination there is pallor and hyperpigmentation in the mouth. Okay. So this is the most finding I can see in the history and in the examination.
Okay. What's your differential diagnosis?
My first differential diagnosis is celiac disease. Okay, because it is very common in young female coming with diarrhea and iron deficiency anemia. Okay. My second differential, also there is skin rash, but not present now. Maybe dermatitis herpetiformis. The second differential, it is inflammatory bowel disease, like ulcerative colitis or Crohn's disease. Okay. Also, this maybe iron deficiency anemia only with irritable bowel syndrome causing this diarrhea, or maybe it is a chronic GIT infection like gardiasis or parasitic infection.
Any other differential?
Maybe hyperthyroidism, but it is no signs of hyperthyroidism here.
What's your workup?
This might. Firstly, I will do the main investigations, basic blood investigations like CBC and liver function test, renal function test, electrolytes and inflammatory markers. After that, I will do iron studies to confirm the iron deficiency anemia, like ferritin, iron. I will do also to confirm the diagnosis of celiac disease, transglutamase glutamase antibodies. Okay. and I will do stool examination, stool analysis, and culture also. And also I will do colonoscopy if needed.
Colonoscopy?
Yes. If I suspect irritable inflammatory bowel disease, if suspected, I will do colonoscopy. About also celiac, we can also do the anti-endomysial antibodies. Okay? We can do also our GIT endoscopy with biopsy also if you suspect celiac disease. Okay. This is all my investigations.
Yeah. How to manage?
If we confirmed celiac disease, it will. I will advise the patient to avoid gluten-containing diet foods. Okay, to avoid like wheat or barley or rye. Okay, and also treat the iron deficiency anemia. Okay, and give also folate and vitamin B12 deficient, or calcium and vitamin D. There's malabsorption. And if it is inflammatory bowel disease, like we can like Crohn's or ulcerative, we can give immunomodulators or if it is ulcerative, we can give aminosalicylic acids, 5-aminosalicylic acids, or biologic therapy if it is refractory. Okay, and nutritional and psychological support.
The last question: what are the cause of hyperpigmentation?
Actually, I can't connect it to any association here. Mostly in this young patient, may be associated to Addison, but it is no signs of Addison here. May be associated as an autoimmune disease, another autoimmune disease, but no relation here. I can't connect it to any disease from this.
Oh, okay, thank you. Thank you, Dr. Hani. So this case is diagnosed with iron deficiency anemia. It is known taking iron supplementation without any effect. So the first task is to search for the cause of iron deficiency anemia. There is physiological cause and pathological. Physiological, the patient is lactating, has high need for iron. This may worsen her condition and has delivery also. Second thing is he has a disease, long-standing disease 2 years ago with steatorrhea. But in the history taking, you have missed screening question for celiac disease. Is it related to you have missed it.
There's interruption in your sound, Dr.
You can say it again, please. Can you say it again?
Okay. There is a specific screening question for celiac disease in the history taking. Is it related to special meat like cereals or pizza? You should ask this question.
Yes, that's right.
Second thing, also in the analysis of the complaint of diarrhea, you have asked about blood, that's good, and steatorrhea, that's good. But you should here also ask about its offensive in order to rule out bacterial overgrowth or tropical sprue, which may be offensive, or bacterial infection as a cause. That's fine. And you reach the celiac disease. Celiac disease is autoimmune disease. And when autoimmune disease, you should search for other autoimmune diseases. Should search for celiac, vitiligo, diabetes mellitus type 1. It's a combi autoimmune diseases.
Dr. Ahmed, there is interruption in your voice. If you can reconnect back.
Okay, I will search from iPad. 1 minute.
So you mean the pigmentation may be related to Addison as association? So Addison and celiac? Anyone can guess this?
Yes, doctor. Because celiac is autoimmune disease and should doing screening for other autoimmune diseases.
Okay, continue. What other things in the history?
He didn't ask about this lightheadedness or dizziness. Is it positional or related? And on the examination, he missed also to offer blood pressure while standing. Skin color changes. It's not only skin rash, but also skin color changes. The patient has vitiligo also. It is a combination with other.
You told me that the patient has vitiligo.
You should ask.
I say skin rash or.
You have said skin rash, but not skin color changes. It's different.
Okay.
Make it as a habit, Dr. Ahani, to ask either skin rash or skin color change or pigmentation. Either hypo or
Yes.
hyper. Okay, add it to your
Yes, that's
approach.
right.
In particular with
Yes.
the autoimmune conditions. Okay, continue, Dr. Ahmed.
So you have missed the half of the case because you didn't search for other causes of this complaint. I have said to you, I have hunger pain, and when I take sugary fluids or sugar, I get better.
So what is the cause of this?
Yes, it's hypoglycemia due to Addison.
Yes.
Should screen. That's my comment. I didn't have.
Okay, what about other skills, Dr. Ahmed? The examination, he fulfilled all examination steps?
Unfortunately, he didn't offer blood pressure while standing. He didn't think about celiac. That's why he didn't ask about any hyperpigmentation of palmar creases. But I volunteered to say to him she has pigmentation in the mouth cavity.
I'll put the line again. And the what about I defined the finding, the signs?
The sign is satisfactory.
Still, he couldn't pick up because he couldn't examine, so he didn't. Yeah. So linked skill. The clinical communication also, you want to minus in the clinical communication because of missing the other autoimmune, right?
Yes.
Okay. The differential. Celiac, irritable bowel, inflammatory bowel disease, right? Malabsorptive diarrhea.
Yes.
And the third?
Yes. Diagnosis in differential.
Again, please, the third differential what?
Addison disease.
Okay, Addison can cause tiredness, yes, of course. So either as association or as a separate condition. Okay.
Association.
Yes, I mean as a differential, because you might say it as the cause of the tiredness, and also the anemia related to the celiac also can cause the tiredness. So both of them can be as a differential. Not only as association, also as a differential. So this is the differential also linked skill. He couldn't mention because he couldn't pick up them. The clinical judgment, he missed Any investigation related to the association? Addison, of course, he couldn't.
Yes.
So still, whenever you miss something related to the condition, it might affect most or many skill. As in our scenario today, because of missing Addison, you'll be minus in the differential, clinical judgment, physical examination, identify the signs. 4 skills might be affected because of missed association or complication or association. The welfare and the concern also, if there is any point to be marked down, anything we missed? I don't think. Did he ask about hypoglycemia and driving?
No.
So it's still one of the important points here. The driving might be also dangerous if he didn't ask about it. Any hypoglycemia. And do you drive? Of course, if he has any of these hypoglycemic attacks. Okay. So the 5th skill will be affected also because of missing the Addison itself. Any comment else you want to add, Dr. Ahmed?
So what is the differential diagnosis here? The arrangement of the Addison will be in the first or what?
Dr. Ahmed, what order you will put the differential here? The celiac and associated deficiency anemia, iron deficiency anemia, then Addison, then inflammatory bowel, in this way,
Yes.
or
Celiac first, complicated
Okay.
with iron deficiency, anemia,
okay,
and the Addison associated.
perfect. Okay, thank you, Dr. Ahmed, for this nice case. So what we can put or add to the clinical communication here, the tiredness itself, one of the constitutional symptoms. So you have to ask about all the other questions related to the tiredness. Sweat, fever, lumps or bumps, loss of weight, loss of appetite, along with the dizziness or syncope, any fainting, any trauma. And also you can add to them blaring, yellowish of your eyes, the jaundice. All these as a constitutional symptoms, you can add it as a relevant system analysis. So put it in your paper whenever you have fever, tiredness, or loss of weight, loss of appetite. You can ask about all these questions together as a package. Again, loss of weight, loss of appetite, fever, sweat, night sweat, excessive sweat, night sweat, tiredness, dizziness, and jaundice or yellowish discoloration of the eyes. Any complaint of them, you have to ask and to complete the other constituent symptoms. Okay. This is regarding the communication as a complaint. Don't forget also to rule out connective tissue disease. It can be also presented with tiredness. But you will have positive finding in the musculoskeletal system. Skin rash or joint pain, stiffness in the joint, back pain also can be also there. I think also relation to the food is very important. Relation to the food is very important because of the flashability. Because of celiac should be asked about relation to the foods. Any relation to pizza or pasta, or even the alcohol itself. Here you can ask specifically about the beer. Okay, so you will rule out celiac or roll in celiac because, or if related to these things. The flashability and the offensive smell and the amount also can be as a confirmatory question. Okay. Anything else? Anyone want to add any comment? Dr. Ala, I saw mnemonic. If you can explain to others, it could be helpful.
Yes, Dr. Bassem. This mnemonic for the all associated autoimmune diseases, when you find one of them, you should ask about the others. So it is CAT MD4B, C for celiac, A for Addison, T for thyroid, M for myasthenia gravis, D for diabetes, 4B, primary biliary cholangitis, and also you can add it to autoimmune hepatitis, premature ovarian failure, and pernicious anemia and primary hypoparathyroidism. So if you find one of them, you should search for the others.
Please can repeat.
You can write them.
Serial?
Yeah, after you mention it, write them. Okay.
Okay, I will write them for you.
Okay. Thank you, Dr. Ala. By the way, if you have any diabetic patient, and this is most common disease, but not every diabetic patient you suspect autoimmune. When you suspect autoimmune association with diabetic patients, this is general question for all of you. When I will suspect the diabetes as autoimmune,
This was age of the patient. Type 1.
exactly. Yeah. So you have to specify the age group. If you have young patient with type 1 diabetes, now I should think about other autoimmune association. But type 2 usually is not autoimmune associated. However, try to also to analyze whenever you have diabetes in a young patient, rule out other associations. Okay, this is a very important question and a very important clue. Any question or comment, Dr. Ahmed, Dr. Hani?
شكرا جزاك الله خير دكتور.
Thank you, بس.
Thank you too. Thank you, Dr. Ahmed and Dr. Hani in particular. Anyone want to add any comment or question?
Any chance this patient had autoimmune polyneuropathy as the patient has Addison and might be has diabetes as well? Celiac.
Perfect. Perfect question. And of course, if there is thyroid, now we have the third limb of the triangle, right?
Yes, Addison is there, so should any one of them
Addison?
can be autoimmune polyneuropathy. This is discussion with examiner can tell like that as one of the part of differential.
Perfect. Yes, perfect. You can add it to the differential, yes. And you have to ask about the thyroid. Any swelling in front of your neck, as well as any weather intolerance.
Any
Okay.
area of glycemia touch the welfare of the patient. When he mentioned to him sugary content, it relieve my symptom, Dr. Hani should ask about, did you measure your blood pressure or anyone measure your blood pressure to confirm Weibel triad? This is confirmed, this is real hypoglycemia. Is that right?
Yes, Dr. Mihira, it's an important question. Whenever you have hypoglycemia, to roll out or to confirm the Whipple trial. So you have hypoglycemia, and what can improve this hypoglycemia? It's improving after having the meal or sugary meal. Yes. So this is sorry.
Yes, and bedside test, blood glucose, and asking about symptoms suggestive of polydipsia, polyuria, because patient might have diabetes itself.
Yeah, and our undiscovered diabetes. Yes, you're right.
Investigation workup for blood glucose, fasting blood glucose, and other autoimmune screening, thyroid function, and even question regarding pernicious anemia, numbness sensation, mood changes. Like Dr. Ala mentioned, we have should ask screening about all autoimmune.
Yes, perfect. The pigmentation is very important to examine, either hypo or hyper.
Yes, and I guess Dr. Ahmed mentioned to him there is elbow rash.
Yes.
This might be dermatitis herpetiform. So our patient might have 3 types of rash: vitiligo, and that for Addison hyperpigmentation and dermatitis herpetiform.
Perfect. Perfect.
Dr. Ahmed, can you confirm you mean
Yes.
this is dermatitis
Yes.
herpetiform?
Yeah, and
No.
he mentioned it, Dr. Hani mentioned it during discussion with the examiner.
Yeah.
He mentioned
Okay.
that
But
the
in
patient.
examination, he should also examine for that.
Yes, right. Whenever you have, I will give you general advice, maybe will be the take-home message in this scenario. Since you have a lot of system impaired or affected, you have to write in your paper that the one you took in the station outside. Write everything positive you will examine. For example, I have tummy pain or tummy or abdominal problem. So I will write in my paper next to the word examination, abdomen. So I will not forget that I will examine the abdomen. What else in this scenario? Thyroid, if there is any thyroid enlargement. So I will write in my paper thyroid. The next thing, the rash. Patient is having rash. I should write also, I will examine the rash, because if I didn't do so, I will forget to do everything. So I have to write what I should examine while taking the history. any positive finding in the history, I should involve it in under the term or under the category of examination. So I will not miss this part during examination. The elbow, no one can examine the elbow unless he remember the herpetiform, dermatitis herpetiforms. Otherwise, or the rheumatoid nodule sometimes. Yes, the elbow can be also important to examine. Otherwise, in the all cases, elbow is not that much important to examine. So two parts or two topics in the cases you can examine the elbow, the rheumatoid nodule in rheumatoid arthritis patient, or dermatitis herpetiforms in celiac disease patient. One important, as I said earlier in the first scenario, Dr. Hani and Dr. Ahmed, I said to you, anyone will offer the vitals. At the same time, ask the examiner, can I do, or what about the posture hypotension? Any change of the blood pressure? So I would like to ask for posture hypotension. He will tell you definitely skip, or he will tell you yes, positive. Because it needs 3 minutes to discover the posture hypotension. And you don't have that much minutes to wait for the result. But you have to offer, I would like to do for posture hypotension. Okay? Any vitals, please make it as a habit. Whenever I'm doing a habit, I'm doing the vital question, I will ask about what about posture hypotension, sir? Okay? He will tell you either skip or it's positive. Okay? I'm done with my comment. Anyone has a comment before ending the session? Okay, now we can end the session. Thank you, Dr. Hani, Dr. Ahmed, Dr. Muhira, Dr. Ala, and all the attendees today. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Okay, good question. To ask about during examination? Yes, during examination. Because you are next to the patient during the examination. You didn't, you are next to the patient now, but not during the history. The history will say if there is any dizziness. But during the examination, if there is posture hypotension, if the patient stands from sitting position. Okay, so you have two questions, either in the history or in the examination. Clear? Thank you.